talk about the multidirectional instability and posterior dislocation. As you know that distinguishing multidirectional instability from unidirectional shoulder instability is very important because many surgical techniques do not address the redundant inferior capsular problems that may lead to early failure and recurrence even for both diagnoses, uni and multidirectional. As you know, the terms, the instability refers to pathological symptoms and loss of function related to the shoulder translation. And laxity refers to asymptomatic physiologic translations of the glenohumeral joint. The multidirectional instability was shoulder initially described by Neer and Foster in 1918s as instability in two or more directions and with symptomatic involuntary subluxation or dislocations. The incidence of multidirectional instability unfortunately unknown, but we know that 5 to 10% of operations for all shoulder instability were caused by multidirectional instability, and its subluxation generally seems 5 times more than dislocations. Typically affected patient's age is between 12 to 35, and it's equal as common in males and females. Generalized ligamentous laxity is very common. That's why the reason it's very important to understand the situation, because 47 to 76% patient has generalized ligamentous laxity. Any history of generalized ligamentous laxity should be investigated because surgery is less successful at that patients. And also patients who have disorders with hyperlaxity syndromes, kind of like Marfan and Ehlers-Danlos, has higher risk for developing MDI. And also labral hypoplasia, glenoid size retroversion may lead to recurrent dislocation. More commonly, MDI occurs in the absence of macrotrauma, but in association with the repetitive microtrauma, generally in swimmers, gymnast players, volleyball players, weightlifters, and others who have performed the repetitive overhead activity. As Ghazi mentioned before, there are several structures, contributors that have been identified for shoulder stability in different range of motion. If the structures damage may result in multidirectional instability. This is the Stanmore classification system. I think it's one of the unique classification system to better understand the all types of instability each other, and that allows for the multifactorial and sometimes shifting nature of shoulder instability. We can classify any patients in anywhere between 3 distinct polar of the triangle. For an example, polar type 1 patients is a traumatic structural history and lesions, and also unilateral instability patterns with normal muscular condition. And polar type 2 patients has traumatic but non-structural lesions, generally uni or bidirectional instability with normal muscle. Unfortunately, polar type 3 is the most challenging group, I think, is because atraumatic with abnormal muscular stature and a bilateral MDI was observed at that patients. There are different instability classifications. One of them, the Christian Gerber, was described. He divides the 3 types of instability: static, dynamic, and voluntary dislocations. It's very complicated and very covered or whole instability pattern. What is the symptoms? Patients may report a history of multiple dislocations or subluxations, which may occur sporadically with specific activity or positions. If the patient has an anterior instability, may avoid overhead activities or abduction external rotation movements. If the patient has a posterior instability, may have pain and instability feelings while pushing objects. And inferior instability generally seen with patients carrying heavy bags or luggage occurred the pain and instability feelings. And physical examination is very important because scapular motion should be observed on every patient's scapular dyskinesia and altered mechanics of the scapula has been shown to occur at higher rates in patients with MDI. The standard assessment of strength and range of motion should be performed in all patients. I like to highlight the important examinations. The Baton criteria should be used to guide assessment of hypermobility. As you know, that higher score correlates with higher risk of ligament dyslexia in Baton index. There are several examinations methods. Gazi mentioned some of them, and including load and shift tests, mostly using in multidirectional patterns, and also sulcus tests for the inferior instability, and also hyperabduction maneuver and apprehension test, relocation test, and posterior jaw test should be assessed to better understand it. There is no gold standard for diagnosis MDI objectively, but based on the original recommendations, Neer and Foster, generally we used this. The sulcus sign, inferior laxity is the mandatory, and we have to plus another direction instability. Depends on the three examination, AP load and shift in two different abduction degree and anterior posterior apprehension test. Two of the tests must be positive, that's three. And radiology, conventional radiology are frequently normal. CT scan may be used for the glenoid dysplasia, retroversion, or the glenoid bone defects. And nowadays the MRI is the golden standard for the patients who has shoulder instability. Furthermore, MR arthrography and MR arthrography with abduction external rotation, giving more information with shoulder instability in multidirectional patients. There are specific findings, crescent sign and triangle sign has a 19% sensitivity and 94% specificity in abduction external rotation MR arthrographic findings. There are different measurements for the multidirectional instability diagnosis. Regarding to the Lee et al. Show the rotator interval width and depth increasing some degree of specificity and sensitivity, and similar findings with Su et al. Describe the rotator interval and the interval area are increasing the patients who had multidirectional instability. For the first step of treatment must be conservative rehabilitation is generally considered to be best initial management strategy for the multidirectional instability. Retraining of the dynamic stabilizers of the shoulder and maintain the humeral head centered over the glenoids may compensate for deficits in passive restraints. There are several exercise programs, and the best and the oldest one, the most popular one, the Rockwood and Burkhardt, reported that 87% good and excellent report outcome, and their multidirectional instability program generally depends on the rotator cuff and deltoid strengthening. The Watson program, the one of the most popular, also focus on re-establishing patient-specific scapular control, typically scapular upward rotation prior to any rotator cuff or deltoid strengthening. exercise progress into the functional and sport-specific ranges into the Watson multidirectional instability program. This is the randomized control study was designed by Warby in 2016 and published in 2018. Researchers hypothesized that the Watson MDI program would produce clinically and statistically superior outcomes over the Rockwood instability program. In this trial, Watson program produced significantly better outcomes than the Rockwood program at 12 weeks and 24 weeks. When we come to the surgery, in non-structural multidirectional instability, surgery aims to restore the passive stability by reducing the capsular volume. Studies have reported good results for inferior capsular shift and capsular plication. This procedure has been described by Neal in 1918 in 36 patients with 40 shoulders. Neal and Foster reported only one unsatisfactory result, one unsatisfactory outcome in their series. Also, regarding the study was performed by James Dubowitz, inferior capsular shift reduced joint volume approximately 57% in the cadaveric study. And arthroscopic plication is described in 1993 by Felix Savea's first time. I think arthroscopy allows the surgeons the full evaluation of the glenohumeral joint, and also it's very useful to avoid complications such as subscapularis failure in the open procedure. How it works? There are two important studies. To decrease the capsular volume is proportional to the size of plication. The Flanagan et al. Showed that increasing plication from 5 to 10 millimeter in every bite led to a decrease the capsular volume 16 to 34%. And also increasing the amount of arthroscopic capsular plication sutures decreased the capsular volume up to 52%, regarding to the study of Pons et al. There's a systematic review was performed by Long, and it's very interesting. The physical therapy patients undergoing the physical therapy required 21% required surgical intervention. On the other hand, in surgical side, the dislocations occurred in 7.5 in open, 7.8 in arthroscopic plication, 24.5 in arthroscopic shrinkage, and 22% redislocations ratio occurred in the laser-assisted capsulorrhaphy. And this one is another important study, shows us how kinematic parameters change with only rehab patients and rehab and surgical patients. Researchers compared the both kinematic parameters and activity of the muscles around the glenohumeral joint at this study. As you see that there are two graphics above that. One of them, the left one, is the physical therapy before, after 2 years and after 4 years with control group. And the right side, the surgical group, and before surgery, after surgery, and 2 years and 4 years results compared with the control group. And there is a statistically difference between the surgical group to the physical therapy group. The kinematic parameters cannot be completely normalized by physiotherapy only. But if you apply the physiotherapy after the proper surgical intervention, the normal rational centers of scapula and humerus may be restored to normal range and maintained at least 4 years, depends on this findings. I would like to quite a little bit add some things about the posterior dislocation, specific as related posterior dislocation. As you know, that it's very rare, and 2 in 10 persons of all instabilities generally occurred in adduction, internal rotation, and anterior elevation position. Locked posterior shoulder dislocations to recurrent posterior shoulder dislocations, we saw a huge different clinics. The young individuals generally is related to the recurrent dislocations. And again, important dilemma, is it unique or single injury? Unfortunately, there are several pathologies described: labral injuries, capsular bulging, rotator interval injuries, even chondral erosions and glenoid retroversions may contribute to pathology. There is not a unique or single injury. Let's see that classification described by Kim et al. Is used for the isolated posterior capsulolabral injuries. According to this classifications, type 1s indicate undetached, type 2 detached lesions, and type 3 contribute with chondral erosions, and type 4 flap tears. There are a few studies that support good and excellent results of arthroscopic treatment and acceptable recurrence rates for the posterior instability. But why is this happening? There are two. When we check the reason of the recurrence, two of the studies seem important to discuss. The one of them, the Bradley et al., show that anchorless suture repair creates a tendency of a recurrence in their series. And the second one, Mauro et al., researched the effects of glenoid, labral, chondral, and bone emulsions and width of the clinical outcomes. Although it was observed that the functional scores of the patients with larger glenoid surface were better results. Unfortunately, the glenoid version between the functional scores could not be revealed. In recurrence cases, they realized the labral width was found to be smaller than 3 millimeter and less than 3 degree in this version. And complications generally seen in the recurrence, range of motion restriction, and the pain complication is waiting for us for the surgical interventions of the multidirectional instability and the posterior labral instability. Thank you.